Hi guys, next up is amyotrophic lateral sclerosis and motor neuron disease. And to increase the awareness of this condition, way back in 2015, when you guys would have been in school, there was a campaign started by the name of Ice Bucket Challenge. So you can see the first image of former United States President Donald Trump, and he's taking that ice bucket challenge. And then everybody in Bollywood, ranging from Amitabh Bachchan to Aishwarya Rai to Abhishek Bachchan, and Akshay Kumar, they all started doing ice bucket challenge, though they did not know the meaning of these terms like amyotrophic lateral sclerosis. And the second image here is of a very great physicist. His name is Stephen Hawking, and this guy was actually the longest living survivor with this disease. He was diagnosed with this way back in late 1980s, and he died in 2018. Traditionally, the survival rate with respect to this medical condition is about 3 to 5 years. Most patients of amyotrophic lateral sclerosis die within 3 to 5 years of diagnosis due to respiratory failure. The longest living survivor of this condition was Stephen Hawking, and this guy, who's a great physicist, he talked about the concept of black hole. The couple of movies also made by Steven Spielberg. He's a famous Hollywood director who's made movies based on the novels that have been written by this guy Stephen Hawking. And this guy was subsequently he was a wheelchair bound patient. Just to explain the severity of the disease, what I can say at this moment is, imagine on yourself that your whole body is paralyzed. You can't move any muscle in your body, cannot move any muscle in your body except your eye muscles. Your ocular motility is preserved. You can look left, right, up, down, that's all. And your gray matter is working fine. Your cerebellum is working fine, but other parts of the brain are getting affected. So in this particular disease, corticospinal neurons get affected. Corticospinal tract anyway gets involved. Even the anterior horn cells in the spinal cord are destroyed, which result in lower motor neuron manifestations. The meaning of the word amyotrophic is because this anterior horn cell is getting destroyed. This means lower motor neuron manifestation, and this will cause denervated muscles. These denervated muscles will start exhibiting development or twitching, that is fasciculations. They would be muscle wasting also developing. And as far as lateral sclerosis is concerned, it means the pyramidal tract also gets involved in this condition. There is a fibrillar gliosis. I mean, from the pathology perspective, the lateral sclerosis in this case explains fibrillar gliosis, which is present in the lateral columns of the spinal cord as well. And the traversing through that area is also the corticospinal pathway. So the peculiar disease that I'm teaching you, amyotrophic lateral sclerosis, is being discussed because this medical condition will be having a combination of findings of lower motor neuron lesion as well as upper motor neuron manifestations. I mean, in neurology, if you get a question in which findings of lower motor neuron as well as upper motor neuron are given in a single MCQ, though I'll talk more technical details subsequently, these are the medical disorders, at least that should be kept in mind, though the list is very exhaustive. Subacute combined demyelination of spinal cord. In SSAD, because of vitamin B12 deficiency, there is demyelination of peripheral nerves, so there would be lower motor neuron manifestations. And because of the involvement of the corticospinal pathway, Babinski sign can also be described, that is upper motor neuron manifestation. So in a question in which he will write the word areflexia with Babinski sign is one SSED. The second one to be considered is the topic of interest which Stephen Hawking was suffering from, that is amyotrophic lateral sclerosis. There is another condition where there is a concomitant cardiac involvement also. There is a presence of diabetes mellitus also, that is Friedreich ataxia. In Friedreich ataxia, he will also talk about cardiomyopathy like hypertrophic cardiomyopathy of the heart, diabetes mellitus type 2 in a patient, along with features of lower motor and upper motor. So though the list is very exhaustive, but I would like you to remember these three diseases from your exam perspective, where combination of LMN and upper motor neuron findings are given in a single MCQ. Now, while I'm describing this, the query in mind of most students is that, sir, why is all this happening? So why is the anterior horn cell getting destroyed? Why are the corticospinal neurons getting involved? And then the corticospinal tract also gets involved. Then from the pathology perspective, in the neurons, in the cytoplasm of the neurons of these patients, there are degenerative changes that are occurring. And these that I've currently shown before you would be referred to as Bunina bodies. So just like you are aware regarding Hirona bodies with respect to Hirano bodies with respect to Alzheimer's, or you're aware with respect to Lewy bodies in Parkinson, Lewy body dementia. I've spoken about tauopathies and alpha synucleinopathies earlier also, but today I'm talking about Bunina bodies, which are gonna be ubiquitin positive. I mean, ubiquitin as a word I have said earlier with respect to Huntington disease also, where I mentioned ubiquitin and Huntington protein. The name is Huntington disease, TON. Last May it's Huntington, right? TON, but the protein is called as Huntington. TIN, Huntington protein with ubiquitin positive. Ubiquitin positive Huntington protein is with respect to Huntington's chorea, but at the moment I'm talking about Bunina bodies, which are again ubiquitin positive aggregates of TDP. TDP is transactive DNA protein 43. So just need to get this data right, that Bunina bodies would be eosinophilic inclusions in the cytoplasm neurons in patients of amyotrophic lateral sclerosis. It's a disease where you have combination of upper motor neuron and lower motor neuron findings. And in that integrated question, he can ask you like, okay, these eosinophilic bodies in the neurons would be composed of. Your answer would be ubiquitin positive aggregates of TDP, transactive DNA binding protein 43, which is present. Well, why do we get amyotrophic lateral sclerosis? There are genetic reasons behind it. It can be sporadic also, but lots of time it can be familial. One of the important genes that is to be remembered by you for the development of amyotrophic lateral sclerosis is SOD1, that is superoxide dismutase 1. This is responsible for 20% of total cases of familial amyotrophic lateral sclerosis. The pattern of inheritance here is autosomal dominant, and on diagnosis, this condition, where after genetic testing, if we demonstrate that this SOD1, superoxide dismutase 1 gene is defective, then the nomenclature that is written in the case file would be ALS type 1 or ALS1. However, there is a very interesting name that I'm mentioning at the moment that would be with respect to chromosome number 9. So it would be written in MCQ as C9 ORF. ORF stands for Open Reading Frame 72 gene. A slightly longish name. Let's do this again. C9 basically stands for chromosome 9. ORF stands for Open Reading Frame 72. This gene, if it is defective and is found to be defective, in fact, in 50% cases of familial amyotrophic lateral sclerosis, the highlight of this gene, which is also autosomal dominant, is that this would be causing hexanucleotide repeats. Traditionally in Huntington's chorea, myotonic dystrophy, we read about trinucleotide repeats. I'm teaching you a disease where cause is hexanucleotide repeats with respect to chromosome number 9, and this would be responsible for 50% cases of familial amyotrophic lateral sclerosis. The pattern of inheritance in this condition is also autosomal dominant, and the bad news for this particular variety is that you not only would be having ALS developing, but these patients would also be having cortical involvement, that too in the form of development of frontotemporal dementia. In fact, I would like to highlight this by using a separate color, that amyotrophic lateral sclerosis patients could be having development of FTD as well, that is a concomitant development of frontotemporal dementia that's present in a subset of cases. So you can understand the amount of disability that I'm talking about would extend beyond, not only the person is going to be wheelchair bound, whole body getting involved, all muscles getting paralyzed, can't eat, can't drink, can't talk. And over and above this, there is a development of FTD as well. The frontotemporal part of the brain is also getting involved. So a combination of amyotrophic lateral sclerosis and frontotemporal dementia is attributed to C9ORF72 gene. So these are two genetic reasons that I would like you to remember. And in the spinal cord, what is the cell that is getting destroyed? Well, this is the cell that is getting busted. This is the cell that is getting destroyed, anterior horn cell. And similarly in the brain also, there are going to be corticospinal neurons getting involved. There's going to be the cranial nerve nuclei getting involved, so there would be a bulbar palsy developing. And if it's going to be the cells which are going to be responsible for the origination of the corticobulbar fiber. See, cranial nerves would be having like cranial nerve nuclei would be like 8, 9, 10 nuclei, and then the nerve is originating. So if the damage is to the cranial nerve nucleus or to the nerve, we call it bulbar palsy. But then we are having even corticobulbar innervation from area 4 of the brain. So in case we are having involvement of the origin of the corticobulbar fibers are also having origin from some neurons, right? So if the corticospinal tract origin neurons, listen to my words there, corticospinal tract / corticobulbar tract origin neurons are getting involved, the manifestations of upper motor neuron manifestations will also be occurring in this condition. I repeat my fact, this is a nasty disease where due to genetic reasons, Anterior horn cells are getting destroyed in the spinal cord, and there could be destruction of the neurons of there could be destruction of the nuclei of the cranial nerves. If we have destruction of the nuclei of the cranial nerves, we don't call it upper motor neuron lesion. That's still lower motor. But if the corticobulbar fibers, the cells from where the corticobulbar fibers are originating, if they start getting destroyed, it's upper motor neuron manifestation. And let's just put this on record. Well, there are a couple of biomarkers for this condition also, which have now been shown to be present. Biomarkers help in early diagnosis even before the clinical manifestations have occurred. So we need to cram this data a bit, that CSF neurofilament light chains, neurofilament heavy chains are found to be elevated, and so is the levels of monocyte chemoattractant protein in this condition. It's identical to, I'll write it and then I'll erase it. In the CSF, we have a biomarker by the name of A beta amyloid 42. This value is found to be lesser in patients of Alzheimer's disease. If you're not listened to Alzheimer's disease, then this might be looking like new to you. But if you listen to Alzheimer's disease, I've said we can diagnose Alzheimer's disease 20 years before clinical features will occur. That test that will help us identify Alzheimer's disease is but 20 years before clinical features will occur. Like suppose disease occurred at 70 years of age, even at 50s or 60s, CSF A beta 42, take care of the words, the A beta 42 levels are lesser, help in early detection. So the advantage of biomarkers is early. I mean, in neurology, the advantage of biomarkers would be biomarkers anyway help in early detection. So CSF A beta 42 amyloid levels lesser versus CSF neurofilament light chains being elevated help in identification of neurodegenerative disorders. If A beta 42 levels are lesser, we are thinking in terms of Alzheimer's disease. If neurofilament light chains / heavy chains are elevated, we are thinking in terms of motor neuron disease / amyotrophic lateral sclerosis. And why these two terms were written separately can be understood from my subsequent information that I provide to you. Because now I'm going to talk about damage to, either we can be having damage to the lower motor neuron of the spinal cord, that is anterior horn cell. And then the brainstem is also having cranial nerve nuclei present, which will contribute to development of bulbar palsy in the patient. Along with this bulbar palsy, lower motor neuron findings will be seen. Person will start having fasciculations in the tongue, fasciculations in the muscles, whichever are innervated with respect to the spinal cord, in leg muscles, in the arm muscles. This asymmetrical pattern of weakness will occur. So if we are having exclusively, now listen to the words carefully, if we are having exclusively lower motor neuron manifestations with respect to both the spinal cord and the cranial nerve nuclei, remember I told you if cranial nerve nuclei are involved, it is still lower motor neuron, then the disease would be called as the technical term that will be used in this particular case would be called as PMA, that is primary muscular atrophy. In contrast, let us now assume that there is a upper motor neuron lesion. What I mean by upper motor neuron is that corticobulbar fibers from where they are originating, the original neurons are getting affected, or upper motor neuron with respect to spinal cord that is affected. In those circumstances, the person will start developing pseudobulbar palsy. Pseudobulbar palsy implies that person will be having features like exaggerated gag reflexes. I mean, if it's upper motor, no, reflexes are exaggerated. So I said exaggerated gag reflex. Like for primary muscular atrophy that are written on the top, gag reflex would be absent. But here, gag reflexes would be exaggerated. And then the voice of the patient will also change. I'll use a very classical term, Donald Duck voice, the quack quack voice that comes. So that Donald Duck voice is seen with respect to pseudobulbar palsy. I'll describe more features of bulbar and pseudobulbar palsy and the differentiating features also as we progress in the discussion. But at the moment, my patient will be having features of exclusive upper motor involvement, that is Babinski sign, or he will talk about brisk reflexes, pseudobulbar palsy. So then the technical term that we will be using for exclusive upper motor involvement is primary lateral sclerosis. You can still see that till now the word amyotrophic lateral sclerosis has not come, because let me put numbers there. If I say lower motor manifestations, primary muscular atrophy, 2 is gonna be upper motor manifestations, that is primary lateral sclerosis. And if I get a combination of point number 1 as well as point number 2, that in a single patient lower motor as well as upper motor manifestations are present, then the technical term that I'll be writing in this case is called as amyotrophic lateral sclerosis. And the manifestations in this chap would be like asymmetrical weakness There would be spastic weakness, suppose in the legs described. Like he will say spasticity noticed in the legs in this person, but in the upper limb on the contralateral side, because I was saying asymmetrical, in the body, in the opposite side, in the hand, there could be manifestations of fasciculations and maybe muscle wasting of the intrinsic muscles of the hand described. I'll say that again. In the right leg of this person, there's going to be development of spasticity. There might be brisk knee jerk present. And in the left hand of this patient, there might be poor hand grip. There might be description with respect to wasting of the intrinsic muscles of the hand, and then even fasciculations described. So that peculiar asymmetrical, because see, Guillain-Barré syndrome is always a fast onset progression over a span of 12 hours to 28 days, or in CIDP, the span of progression of weakness can be longer. But then in GBS, we are having, or even in CIDP, we'll be having symmetrical ascending flaccid paralysis with albuminocytological dissociation present. In this condition, there would be no mention of any albuminocytological dissociation, and the weakness in this condition will be progressing not over days, not over weeks, but over years altogether. So it's a asymmetrical distal weakness. Mark my words there. It's a asymmetrical. In GBS, I was saying ascending symmetrical. Now I'm saying asymmetrical distal. Distal means in the hand and in the feet. So he can fall. He can have. He can trip multiple times. In fact, with respect to Stephen Hawking, there was a movie made also in which you can see. If I zoom into this image, you can see that he's standing with help of a stick. So he started having these recurrent falls because he started having weakness in one of his legs, and then he started having fasciculations in the left hand. So that's the kind of a description, and this could be like in 1980 he started having this weakness in the leg, and 1982 he started having weakness in his left hand. So like over a matter of years, this progressive weakness would occur to the level that subsequently the person cannot even talk, because bulbar palsy will start developing, or maybe even pseudobulbar palsy would start getting or start developing in this person. In fact, the only thing preserved in this condition towards the later phases of illness would be ocular motility. Bladder and bowel control would be maintained, ocular motility will be maintained, and gray matter, in case frontotemporal dementia is not occurring, would be, the cognition part would be well preserved in case he does not develop a frontotemporal dementia. So the main message is, if we are having only lower motor manifestations, primary muscular atrophy. If we have upper motor neuron manifestations, we call it primary lateral sclerosis. If we have a combination, it is amyotrophic lateral sclerosis. And then, as I explained, some varieties of ALS can be associated with FTD. So that would be a subset that anyway has to be remembered. And now let's compare the clinical features of the disease. Though I've given you a heads up, let's do it like we have done for Guillain-Barré syndrome. In this question, he will describe that in 2023, in this individual, there was weakness with respect to legs, or weakness with respect to spastic weakness. Spastic weakness will manifest most of the time in the form of cramps. Like this guy is physically active, but he says, I tend to cramp up a lot, so I've stopped going to the gym. And then in 2024, in the opposite hand of this person, he is like holding a glass in his hand, he's trying to drink something, and the glass slips from his hand. He thought it was an accidental drop of a glass, but this has started occurring on a frequent basis. And because of the distal weakness, he'll also have difficulty in turning on a doorknob. He might be having difficulty in switching on, the ignition key of a car. So distal weakness would be present for this particular case. I'll just jot it down. In patients of amyotrophic lateral sclerosis, we have an asymmetrical distal weakness, but gradually all muscles of the body, one after the other, will start getting involved. So in the later phase of the illness, there would be a symmetrical weakness. When I say this, most students get confused. They say, sir, tell us one thing. Is it asymmetrical? Is it symmetrical? Initially, it is asymmetrical. Like I have shown here that right leg and the left arm, and that to right, I would say right ankle and the left hand is getting involved. But gradually, by 2025, both hands will get involved in a person. No? So then it will become symmetrical distal weakness in an individual, and then it will progress to involve the shoulders also. So proximal weakness will also come. So because this disease tends to involve gradually multiple levels in the spinal cord, bulbar, cervical, thoracic, lumbosacral. So gradually in the later part of the illness, you will be having symmetrical bilateral weakness, but the starting of the illness would be very peculiar asymmetrical distal weakness, which would be spanning, the weakness would be the interval between this weakness between the upper limb as the lower limb can be ranging between a month to a year as well. Now, as far as the weakness is concerned, most of the time, as I explained, it would be a distal weakness. So, how would he write this distal weakness? He might write in the form of either recurrent falls, or he might be having to use a stick, or he might, if you are having for describing the recurrent fall thing, let me say, if you're walking on a slippery surface, or if the floor is wet, you will try to walk a little, tread a little carefully on a wet surface. But a person who is having ALS weakness, then when he's walking on a slippery surface, he might slip, and he might say that a lot of these patients might laugh off their illness as that I'm a very clumsy person, I keep on falling. But there's a reason why this is happening in this person. Another reason why they can come to you is if there is going to be spasticity. Spasticity mainly will be involving like hamstrings. So cramping will also occur. So if this guy is, let me say, uh, avid gym user on a regular basis, he might be saying that, doctor, in the morning I just got up, I was stretching and suddenly got a cramp in my leg, and because of these cramps in my leg I was not able to go for my workout. And initially he kept on neglecting it. He thought that he maybe pulled a muscle in the gym, but since has become unbearable and every day is having substantial amount of cramping, when he came to you, you found that this was not a routine hamstring cramp that can occur in a physically active individual. This was a spasticity, and when you check out the reflexes in this person, it would be found to be brisk. Similarly, in the same patient, in the follow-up visits, you will notice that there would be development of muscle wasting. This muscle wasting can also be described in the contralateral leg also. Do not be under impression that wasting or twitching or fasciculation, always this pattern will be like right leg or right ankle and the left hand of the patient. No, it could be the contralateral leg getting involved also, but after a variable period of time. And anyway, in this condition, in lumbar puncture, there would be no mention of any albuminocytological dissociation. Most of the time, extensor weakness is more commonly seen as compared to the flexor weakness of these individuals. Because of this extensor weakness, what I can say is that there could be a wrist drop developing in these patients. As the disease will progress, it will also contribute to bulbar palsy, because bulbar palsy, there would be difficulty in chewing. So we might have to, the risk of aspiration pneumonia is too high, we might have to put in an NG tube, and even if that gets dislodged, there can be risk of pneumonia. So it would be advisable to go in for a feeding gastrostomy or jejunostomy in these patients. Difficulty in chewing, difficulty in swallowing, difficulty in speaking, difficulty in drinking, all of these would be encountered primarily because of bulbar palsy, and then in some of these patients even pseudobulbar palsy can be developing. Before I describe the pseudobulbar palsy manifestation, I would like to incorporate one of the main reasons why these patients can die, that is respiratory weakness, respiratory paralysis, and that is why ventilatory support might be required in these patients in the later stages. We might have to do tracheostomy in these patients, and then prolonged intubation will cause a tracheal stenosis. So I would like to do a tracheostomy and cut down on the dead space as well, and then ventilate this patient to prolong the survival. As far as the pseudobulbar palsy is concerned, one of the key words that can easily differentiate between bulbar and pseudobulbar palsy would be the word exaggerated gag reflex. But that would make it relatively easier for you. So in some of MCQs, he might describe this classical term, that is a Donald Duck voice, which basically is the dysarthria component that would come in these patients. And another feature that can be again a very good pickup point in question is exaggeration of emotions, because there might be a sudden, he might laugh in a very peculiar fashion, or he might suddenly start crying, something like an emotional outburst. Like, here I am talking to you, and suddenly if I start crying, you would be taken aback. No, sir, you were talking and suddenly you have started crying. So that lack of control over emotions, because the reflexes are faster, because the muscles are in a spasm, and as a result of it, I can say that there would be exaggeration of emotions in these patients. This can cause an uncontrollable crying in this individual, or involuntary weeping in this patient, involuntary laughing as well. This might look very peculiar to family members initially, that they suddenly, without a reason, the person is beginning to cry. Not that the person is a dramebaz, like, some people, they can cry just at the drop of a hat, and they are like actors. No, sometimes actors, they're very spontaneous. Like, look at Shah Rukh Khan and all these guys. I mean, they can just, act very, very fast. I mean, they can change their facial expressions very fast. So I'm not talking about an actor at the moment. I'm talking about a genuine exaggeration of emotions, exaggeration of reflexes per se. So involuntary crying, involuntary laughing might be noticed with respect to pseudobulbar palsy. And obviously, I mean, a good pickup point, if he's a little kind on us, he might mention regarding a brisk gag reflex, whereas this gag reflex would be found to be absent with respect to bulbar palsy. The highlight of this disorder, one of the main reasons why this topic is being discussed at this point, is to remind you that just like when I was describing Guillain-Barré syndrome, I was saying no, that bladder and bowel are preserved. Similarly, in this condition, the good news is that the sensory system is intact, the bladder control is intact, the bowel control is intact. So at least that unhygienic aspect that comes with Alzheimer's disease, Parkinson disease, where person might urinate in his pants and not make attempt to clean himself, that kind of a manifestation would not be seen in these patients. In majority of cases, in case I mean, it's not associated with that C9orf72 gene, then the cognitive functions of the patient will also be preserved. Though I said this can be a subset, no, ALS can be associated with frontotemporal dementia, but if that is not happening, then even the cognitive functions would be preserved in this patient. So there are four things, in fact, five things that are going to be preserved in this condition. The five things that are preserved in this condition is ocular motility. Till the very end, this guy, Stephen Hawking, was academically, he was a physicist. So till towards the very end, he was able to read books. Because how did we know that he's reading book? Because if you're reading a book, your eye would be having that saccadic movement, no? So the ocular motility in him was preserved. And in fact, there were special devices. In fact, with technology, subsequently we will start having our phones, which we can control with the movement of our eyes. Now we have Siri, we need to speak and we give a command and Siri will open a page for us, or we are having Alexa and Alexa will do a task for us. But subsequently there can be devices which can be reading your facial expressions, and not only a facial expression, just with your eye movement, like you blink two times and maybe Google will open, and if you blink three times, maybe some other channel will open. I'm just saying or extrapolating that. I mean, look at the technology that they're developing for people like these, that with your eyes you can control an electronic device. That would be a blessing for these particular patients. So what is preserved in this condition? Well, preserved in this condition is ocular motility. Preserved in these patients is cognitive functions, sensory functions, bladder and bowel functions are preserved in this condition. So a lot of time MCQs that will be asked on this topic will begin by describing weakness. He'll make it sound as if he's talking about GBS, but you will be picking it up on the basis of electrodiagnostic studies, albumonocytological dissociation, previous history of Campylobacter jejuni infection. I mean, there would be some trigger before GBS has occurred in an individual. In this case, it's going to be gradual onset manifestation, possibly recurrent falls or not being able to use a gym, wasting of intrinsic muscles of the hand, development of a wrist drop would be described. And then this is really bad news, because if he can't eat, he can't chew, he can't talk, that's when they can develop even aspiration pneumonia and can die. But in spite of all the handicaps, you can see eye movement is preserved, brain function is preserved if he is not having that C9orf72 gene defect, and then bladder and bowel function is also preserved in this condition. The next thing that I would like you to remember for this topic is that the broader term is motor neuron disease, and this motor neuron disease incorporates multiple disorders. Like if exclusive lower motor manifestations are present, we call it primary muscular atrophy. If it's going to be exclusive upper motor, we will say primary lateral sclerosis combination, that is ALS. And then there's a subtype also of ALS which is associated with frontotemporal dementia, but the broader term is motor neuron disease. Now, if bulbar area of the brain gets involved, we can be having difficulty in chewing, swallowing, talking. In contrast, cervical spine, there could be wasting of the intrinsic muscles of the hand. If it's thoracic, that would be paraplegia developing, spastic paraparesis developing. So if out of these four areas, at least three would get involved, then we will say that patient is having a definitive amyotrophic lateral sclerosis. In contrast, if two out of these four areas are involved, then we will say that he's having probable amyotrophic lateral sclerosis, and the broader term that is present here is motor neuron disease. Let's now look at the differential diagnosis that must be ruled out. One is obviously the tumors of the cervical cord. That's because cervical spine involvement will cause lower motor at the level of the lesion, upper motor manifestations below. Next is a very interesting disorder. The name is multifocal motor neuropathy with conduction block. In fact, this particular disorder is associated with anti-GM1 antibody. And the last time I spoke about anti-GM1 antibody, remember that was Guillain-Barré syndrome. So in GBS, we have albuminocytological dissociation and anti-GM1 antibody is present. The same antibody is present even here for MMN, that is multifocal motor neuropathy with the conduction block. More details of this will be filled in towards the end of this discussion, but that's one of the important points to be remembered. The same antibody that we read about in GBS, that is the commonest variety AIDP, acute inflammatory demyelinating polyneuropathy, anti-GM1 antibody is also found in multifocal motor neuropathy with the conduction block. The name is self-explanatory. That is mainly it is the peripheral neuropathy manifestations that would be occurring, but the antibody seen in this condition is identical to the one that is seen in GBS. The third important differential is lymphoreticular malignancies that could be like multiple myeloma or lymphomas. Then Lyme's disease. For Lyme's disease, there would always be a CSF pleocytosis present. This CSF pleocytosis is not encountered in amyotrophic lateral sclerosis. Then is a toxin that would be lead poisoning. Lead poisoning would be picked up on the basis of one, the key word in the MCQ, basophilic stippling of RBCs. Then because it will interfere with heme formation, the precursors of heme formation, ALA, amino-levolinic acid levels would be elevated. So every time you read about urinary ALA levels being elevated, basophilic stippling of RBCs, it is lead poisoning that should come to our mind. Poliomyelitis anyway has been eradicated from India. So though it is described as one of the differentials that has to be taken, because poliomyelitis is anterior horn cell disease which causes lower motor manifestations. So that's one of the differentials that is to be taken into consideration. But on this particular slide, apart from the differentials, I want you to remember 3 out of 4 areas getting involved is definitive amyotrophic lateral sclerosis. If it's going to be 3 areas where only lower motor manifestations are present, then I'll be not using the word ALS, then I'll be using the word primary muscular atrophy. So I mean the core concept here is that at least 3 areas should be involved for a definitive diagnosis, clinical diagnosis of this condition. Coming to the treatment of this condition, there is no definitive drug or choice per se, but yep, one of the drugs that has been found to improve survival, especially prolonging the life of these patients, riluzole, and was used in Stephen Hawking as well. Then at the time of death of Stephen Hawking, a drug was approved and that was asked by AIMS people. So AIMS people are like very updated, and that was I think way back in 2018 that they put up this question, that recently approved drug. I mean obviously it's not recently approved anymore, it's like almost 5-6 years now, but then edaveron has been asked in the exam as the recently approved drug. So you'll find it in the PYQ section. Then there are 2 more drugs I would like to mention before we'll talk about supportive interventions that we'll be doing in this patient. That is gonna be phenylbutyrate. The main objective is chest physiotherapy. See, because respiratory illnesses are one of the main reasons for killing most neurological illnesses. No, Alzheimer's disease patients will die because of pneumonia, or Parkinson disease patients will die because of pneumonia. In this case, I did not say the word pneumonia, though I said respiratory failure. But ultimately, even in these patients, risk of aspiration is very high in the setting of both bulbar as well as pseudobulbar palsy. The 4th drug that I'm mentioning is tau or sodiol. And apart from these 4 drugs, what else can be used would be cuff assist device, because this guy has lost his gag reflex. He has lost his cuff reflex, and because of this, the ability to cough out the lung secretions or cough out the secretions in the chest would not be possible. A lot of these patients, because they go into respiratory failure, there might be a requirement of performing a tracheostomy. We may not even get consent for it. I mean, it looks very horrible to say to somebody that we're gonna make a hole here through which we're gonna put in a tube, and most of the time the family members just respond to that with dropping jaws, and it's like, how could you say this, and how would you be doing it for a family member? I mean, how the quality of life is gonna be. But yeah, I mean, we might be requiring a full-time nurse at the house of this person, so that feeding of these patients via gastrostomy or jejunostomy tube can be taken care of. And as I was saying, there are multiple devices that are being developed for these patients that we could be having a speech synthesizer so that at least he can communicate on the phone, or like the newer researches where you could be having your phone that could be controlled with the movement of your eyes as well. So technology has a long way to go as far as management of amyotrophic lateral sclerosis slash motor neuron disease per se is concerned. And overall, if he says what is the most common type of motor neuron disease per se, then the overall commonest type of motor neuron disease is ALS, about which I spoke as Ice Bucket Challenge. Was a campaign started way back in 2015 to increase the awareness regarding this condition. The next topic that we're studying is spinal muscular atrophy. This is a pediatric variant of motor neuron disease in which there's a defective gene that is called as SMN gene. The full form of SMN would be survival motor neuron gene. And well, the reason why I am talking about this condition is because it was in the news recently where the Sonu Sood, especially campaigning for saving a life of a child with spinomuscular atrophy. And there's a new drug that is available for management of this condition, which is horribly expensive. In fact, the cost of this drug, if you will Google it, the single vial cost can go up to 80 to 90 lakhs. The total cost of treatment can go up to 6 crores in a patient. So I said that Sonu Sood was campaigning for saving a life of child with spinomuscular atrophy. So I mean, why was he doing that crowdfunding, or why they were having this donation campaign on? Because the treatment is horribly expensive. We are using antisense oligonucleotides for management of this condition, and one of the important antisense oligonucleotide, which is one of the, I would say, horribly expensive drugs. Well, pharma sector is I would say brutal in a sense that they don't give a damn. They'll produce a drug, but then I mean 80 to 90 lakhs per injection is something which most of the time would be beyond the reach of any Indian family, even if it's an upper middle class. And then the couple of subtypes of spinomuscular atrophy also, which have peculiar names. So let me just jot them down. There are three varieties: type 1, type 2, and type 3. Type 1 will be having an infantile presentation. Type 2 will be having a child onset presentation. Type 3 will be most of the time late childhood going into teenage when the presentation will occur. For the infantile variety, this child after birth will be hypotonic, because spinomuscular atrophy, as said, is like a pediatric variant of lower motor manifestation of motor neuron disease, that is primary muscular atrophy. So here the word is spinal muscular atrophy. Child will be having no reflexes after birth. He would be a floppy baby. There's a differential diagnosis of floppy baby. Many of them, one of them is spinomuscular atrophy. So even when the baby was a fetus, the mother had reported that fetal movements were lesser with respect to this baby as compared to her previous children. Normally, a lady is able to appreciate quickening. She is able to perceive fetal movements, but this child had less fetal movements. And after birth also, the movements are relatively less. This is a floppy child. The reflexes of the child are depressed, and at the same time, even milestones of the child, especially the motor milestones like sitting with support, sitting without support, they would not be possible because of the gross hypotonia, because the anterior horn cells of this patient are destroyed. In this infantile variety, the classical name that you should be aware of is Werdening-Hoffmann, and that could be a terminology that could be in the present in the MCQ with respect to that. Whether this will cause upper motor or lower motor manifestations. As I've explained, this would be destruction of anterior horns in the spinal cord, so this would be lower motor neuron manifestation. And then there's a special name for the type 3 variety also, that is called as Kugelberg-Vilander syndrome. So a couple of tongue twisting names I would say at the moment, but I think worth the effort. So Werdening-Hoffmann is spinomuscular atrophy type 1. And then I said Kugelberg-Vilander syndrome. This is going to be type 3 variety, and a new drug available for this, horribly expensive, is nusinersen. Next up, we'll talk about another very interesting disorder, that is multifocal motor neuropathy with a conduction block. And this can also begin like in ALS or motor neuron disease as a distal upper lip weakness. The manifestations could be in the form of one, that the hand grip of the patient will be weak, because of which objects might keep on slipping from the hand and you might think that he is a very clumsy person. And the second could be wrist drop as well. So at this moment, the diagnosis is wide open because there are multiple reasons contributing to wrist drop and a weak hand grip as well. But then the evidence would come from electrodiagnostic studies, which will be showing that in this condition, there will be a focal demyelination. The next thing that I say is the most important point of this particular topic. There would be focal demyelination of the spinal motor neurons. When I started this topic for motor neuron disease, I was talking about destruction of the motor neurons, but now I'm not talking about destruction, but I'm talking about demyelination of the motor neurons. The antibody which is responsible for this focal paranodal damage, why it's, because it is paranodal, that is why the word conduction block is there, because nodes of Ranvier are getting attacked by this antibody. And we traditionally read about this antibody even with AIDP, that is acute inflammatory demyelinating polyneuropathy, and AMAN, that is acute motor axonal neuropathy, which are two subsets of Guillain-Barré syndrome. But in GBS, we tend to have a segmental demyelination. We have a fast onset progression happening. In amyotrophic lateral sclerosis, there's a slow manifestation. Even with the multifocal motor neuropathy, it's a very slow manifestation with respect to weakness first starting in the upper limb, and later even a foot drop can be developing in this patient. And the last point that I say is again very peculiar in a sense that the treatment or choice for management of this condition would not be answered as riluzole or edaveron, though this is a gradual onset, slow, asymmetrical distal weakness developing. For treatment of this condition, we'll be using intravenous immunoglobulins, or we can be using rituximab. And then rituximab per se was again not mentioned even with GBS. So you can see that our conditions where intravenous immunoglobulins are used have increased. I mean, intravenous immunoglobulins, where do you read about them now? You read about them in Kawasaki disease, you read about them in Guillain-Barré syndrome, and now we are also reading them about them with respect to multifocal motor neuropathy with a conduction block. MMN is multifocal motor neuropathy with conduction block. And even with respect to myasthenic crisis, you see myasthenia gravis can worsen, and therefore myasthenic crisis can occur. Those are the situations where intravenous immunoglobulins have been used. And rituximab is again used in hemat multiple times, like in non-Hodgkin's lymphoma. So we'll talk about rituximab with respect to hematological perspective. But at this moment, one, I just wanted to remember that every time we talk about anti-GM1 antibody, just have a look at it from the progression perspective. Slow onset progression, like the one that I've written, and after subsequently even the foot drop could be described in this patient. I mean, this is not the way GBS would be presenting. So don't, every time you read about anti-GM1 antibody, don't straight away think in terms of GBS, and think in terms of possibility of our differential for amyotrophic lateral sclerosis. That would be multifocal motor neuropathy with the conduction block, which was mentioned in even the differential list. And I had said that I'll be describing more information with respect to this in the later part of the discussion. So these are the details that I would like you to remember for this topic. I know that it took a while for you to, reach up to this particular stage in the app, but then if you're doing it, yes, you are becoming stronger on a daily basis. And that's all it's all about. I mean, it's all about mental strength. It's all about mental toughness, and that tends to develop over time. I mean, nobody is born mentally tough. It's that you acquire this trait over time. And doctors are about, I would say, one of the most mentally tough people, because they handle so many subjects. They handle, I mean, personal crisis of people. Handling personal crisis of people takes a part of you. If somebody is crying in front of you that my dad is having cancer, or a person with cancer is crying before you, a person with neurological illness is like totally devastated, and he can't even eat. He's urinating, he doesn't know that he's urinated in front of a doctor, and he's unhygienic. I mean, that to understand that sad part of somebody's life is taking a part of you. So I mean, why do doctors develop gray hair earlier as compared to ordinary population is primarily because to understand pain, to understand, I would say, illness of somebody, the empathy part that we have, I mean, that's inbuilt, guys. I mean, you need to be proud of yourself that you are able to relate to somebody's illness, and then you try to get him out. Though Indian patients will not respect you for that. Indian patients are nasty ones and very demanding ones, which is why, I mean, you need to keep on learning new facts every day. So thank you so much for hearing me out.